This presentation will look at what type of drains may be seen on patients post-cardiac surgery and what the function and use of these drains are. We will also be discussing how to care for these drains post-operatively, how to observe output and action of these drains and what this means. There will also be a brief overview of how to document drain losses and when and why it is important to escalate any changes that is observed. Part of this presentation will also be a brief recap on what to do if there is accidental displacement of a chest drain. On CICU, we mostly come across 3 drains that are used in cardiac surgery. These drains are the pleural drain, the mediastinal drain, and the PD drain, also known as the peritoneal drain. Dependent on the surgery a patient has had, there may either be 1, 2, or all 3 of these drains present. Each drain is placed for its own specific purpose, and it's important to be aware of the function of each drain and have an idea of its exact placement in the body. Most patients that arrive post-surgically on the CICU have a pleural or mediastinal drain or both. These drains predominantly have a similar role in terms of removing unwanted fluid from an area inside the cardiothoracic cavity to the outside of the body. A pleural drain sits between the lung and chest wall, known as the pleural space, and is present to remove fluids such as blood, empyema, and even air. The mediastinal drain sits within the mediastinal area of the chest cavity and is present to remove any excess fluid, blood, or blood clots from around the heart. Some patients may return with a peritoneal drain, also known as the PD catheter. This drain is inserted into the peritoneal cavity of the body. This catheter is useful in patients who have had or are at risk of acute kidney injury, and the catheter can be used for PD dialysis if required. So when a patient arrives onto the CICU post-surgery, there are a few simple steps that can be taken to ensure best nursing care of chest drains. Firstly, it's important to ensure that all appropriate equipment required to take care of chest drains are present in the bed space. This includes things such as chest drain clamps and chest drain bottle holders. On arrival to the CICU, drains must be attached to suction as soon as possible. It's important to ensure that the suction tubing is available for connection and already connected to the suction. Theatre staff or the resource nurse can then attach the suction to the chest drain. Suction for chest drains should be set at 4 to 5 kPa. Drains should be placed into a chest drain holder to prevent being knocked over or spilt. On arrival, it is also vital that drain output is documented as soon as possible. We will discuss how to document chest drain losses later in the presentation, but it's important to have an awareness of how much is present on arrival in order to be able to acknowledge any significant drainage post-patient transfer. All drains should be visibly labelled with the appropriate stickers. These can be found in the top drawer of the infusion trolley on CICU. Drains should, when able and at the earliest opportunity, be secured as per guidelines. This helps prevent accidental displacement of drains as the patient starts to wake or when cares are being undertaken. On arrival to the CICU post-operatively, it is vital that chest drain observations are undertaken. This allows us to monitor how much drainage occurs through chest drains. Observations of chest drains should be documented on the allocated CICU drain chart observation sheet. Observations should be recorded as follows: every 15 minutes for 4 hours, followed by every 30 minutes for 2 hours, followed by hourly for 2 hours. After 8 hours, drain losses may be recorded on the regular ICU chart. If drain losses regularly exceed more than 3 mils per kilo, it may be required to extend how long we closely monitor the losses for. Only pleural and mediastinal drains are to be documented on the chart. PD drains should be documented on the regular ICU chart. Any volume or blood products that are given to the patient should also be documented on the ICU chart. When a patient arrives from cardiac surgery, it is important to identify whether they are chest open, skin closed, or chest closed. This plays an importance on how drains are placed on suction. If a patient is chest open, drains should be placed on intermittent suction only. This suction should be applied for approximately 5 to 10 minutes before being stopped. If a patient is chest open, skin closed, then drains can be placed on a continuous suction. You can confirm this with surgeons post-arrival. Please be aware that if drains are on continuous suction, cardiovascular compromise can occur, so it's important you are vigilant. If a patient is chest closed, drains can be placed on continuous suction. When suction is not being used, tubing should be removed from the bottle and placed into a clean glove, as suction that is off and still attached to a chest drain equates to a drain being clamped and could potentially cause pneumothorax. As part of monitoring and observations of chest drains post-surgery, it is important that when documenting chest drain losses, we document the behaviour of the drain in order to identify any changes. On CICU, we use the following abbreviations: SW for swinging, B for bubbling, S for suction, and 0 for still or static. Swinging of a chest drain indicates that the chest drain is patent. During patient respiration, you should see the fluid from the underwater seal oscillate up and down the tubing. This is due to the change in intrathoracic pressure during ventilation and respiration, and ensures us that the chest drain is still sited within the pleural cavity. Bubbling of a chest drain can occur due to air escaping the pleural cavity through the drain and presenting in the underwater seal. This can indicate a need for continued presence of the drain. Bubbling can also occur due to the release of air from the pleural cavity in the presence of a pneumothorax. This should be closely monitored. If the presence of bubbling occurs that was not present before, this should be escalated immediately to a medic. If the drain previously was bubbling and is now swinging or static, this can usually indicate that the air leak has been resolved. However, observation should be undertaken to ensure that the drain remains in situ. It's important that regardless of any changes to the behaviour of chest drains, they are all reported. At times on the chest drain chart, you will see the letter S documented. This indicates that the chest drain is on suction. During this time, it would have been identified that the drain is working efficiently and at times still draining when needed. Occasionally, a drain can be taken off suction to assess for swing. In some instances, you may see the letter O documented under the behaviour section of the chest drain chart. This occurs when the drain is no longer draining or if an air leak has been resolved and there is no further fluid being drained through this drain. On CICU, drains will remain on suction unless otherwise instructed, and this form of documentation is normally found on the ward. So as previously mentioned, after 8 hours, the chest drains may then be documented on the regular ICU chart. This is just a brief overview of how to include chest drains into the ICU chart to enable a total fluid balance. Firstly, PD drains are documented on the normal ICU chart from the beginning of admission. Each hour, you need to transcribe the running pink total from the drain chart into the hourly drain section of the ICU chart alongside the PD losses. You then add up the total output inclusive of the NG, urine and drains. This will provide you with an overall balance per hour on the main chart. This will then correlate when the drain's output is then continued onto the ICU chart after 8 hours. If you are still unsure of how to do this, please speak to one of the CICU nurses who can help explain it in person. This slide will look at what to do should drain output suddenly increase, or if there is consistent drainage of more than 3 mL per kilo. Increased drain output may not necessarily mean there is an issue, but it can indicate situations such as internal bleeding. Regardless, it is always important to alert a medical professional if output exceeds more than 3 mL per kilo. In some cases, a larger output may be expected, but this should be communicated between the surgical, medical and nursing teams during post-surgical handover. If output is more than 3 mL per kilo, it's important to undertake the following. Medical and cardiac teams should always be informed. Patient observations should be monitored closely, including blood pressure, CVP, heart rate, and in some circumstances the LA pressures. If a patient shows cardiovascular compromise, consider volume replacement either in the forms of colloid or crystalloid, depending on what is appropriate for the patient. Blood samples such as full blood count and coagulation should be sent to observe patient hemoglobin and clotting factors. If required, these can also be rectified with appropriate products. Drain observation frequency should be increased as appropriate, and the observation should be made with regards to the contents of the drainage. Is drainage frank blood or is it serous fluid? It should be discussed with medical teams and cardiac teams as to whether patients require a repeat echo to look for accumulation of fluid or blood in the chest cavity. Lastly, if a patient is receiving coagulation therapy in the forms of heparin, this should be considered. Heparin may play a part in blood loss of patients. However, the risk of whether to continue heparin or stop heparin needs to be evaluated by the appropriate teams. It is also important that it is understood what it means when drain output is reduced. When drain output is reduced, it is normally an indication that excess fluid that is accumulated in the mediastinal or pleural cavities has been reduced or that drainage has completed. However, this should not just be assumed, and the observation of the drain as a whole must be undertaken. Reduced drainage could be due to the fact that a chest drain has become kinked, meaning that drainage cannot occur. It is important that drains are checked for kinks or restrictions. By doing so, you are ensuring that things such as clamps are not in situ on the drain, or that the patient is not lying on the drain and restricting the drain output flow. It should also be assessed that the drain has not become blocked by clots or fibrous strands. A blocked drain may cause accumulation of fluid, or if a drain such as the pleural drain has become blocked, this can result in pneumothoraces or tension pneumothoraces. If a blockage is a concern, the drain needs to be assessed by a relevant person such as a cardiac surgical registrar. This drain can then be flushed by the cardiac surgical registrar in order to allow drainage to resume, or a new drain can be inserted. The final slide of this presentation will look at what to do should a drain become accidentally disconnected. Firstly, the drain should be clamped at the patient end closest to the patient as quick as possible. A medic should be alerted and help should be called for. A new sterile drain should be set up as per protocol and attached to the chest drain. Once attached, the clamps may be removed. It's important that a chest X-ray is done as soon as possible to look for indications of potential pneumothorax. A day tech should be completed in order to identify what occurred and help identify ways to prevent this in future practice. Family should be informed as soon as possible, and they should be made aware of what was done in order to rectify the situation.